Okay, so rhabdomyolysis. So rhabdomyolysis is the result of some sort of skeletal muscle injury. So we have a myocyte injury, which is again our muscle cells, which is going to result in a failure of energy supply within the muscle. So this could be a result of hypoxia, this could be a result of DKA, this can also be a result of an actual trauma, this can be a result of ischemia, this can be a result of even like immobility. So reduction in ATP is going to disrupt our electrolyte channels and concentration, which is also going to disrupt the fluid concentration within our muscle cells and cause myolysis. So myolysis is going to be the breakdown of muscle tissue and muscle fibers into our bloodstream. And so this myolysis is what's going to cause the renal, so the acute kidney injury that we are going to see. So we have damage to our glomerulars of our kidneys, resulting in acute kidney injury, and then electrolyte disruption, again, from the changes in our ATP production within the muscles, as well as decreased renal function. So causes some of our medications, like statins, so Lipitor or atorvastatin can cause rhabdomyolysis, as well as like a lot of our psych meds can cause rhabdomyolysis. We can see it in trauma, we can see it from compression injuries, so whether something falls on our patient or they have some sort of decrease in blood flow and develop like compartment syndrome can cause rhabdomyolysis. Increased exertion, so triathletes, ultramarathon runners, bodybuilders who like aren't prepared can actually cause muscle damage and muscle breakdown. Muscle hypoxia, hyperthermia, we can see this from, as well as hypothermia from that increased shivering. DKA, some toxins, as well as immobility can all result in rhabdomyolysis. So signs and symptoms, so first is going to be myalgia. So myalgia is just muscle pain as well as muscle weakness. And we'll see this T-colored urine. So T-colored urine is when we're starting to have renal impact. So our kidneys are now involved. This is going to be a sign of acute renal failure and organ damage, high risk of morbidity and mortality in patients when they start to have that renal impairment. Tense or swollen muscles on examination, especially if it's like unilateral. A tachycardia, fever, nausea, vomiting, and it can eventually lead to disseminated intravascular coagulation because we're going to have that epithelial damage because it's either from hypoxia, hypothermia, hyperthermia, as well as that myelosis. So we're going to end up with a bunch of microclots within our muscular system. So diagnostics for rhabdomyolysis is we're going to check a creatinine kinase. So creatinine kinase is going to be from muscle breakdown. Alright, it'll be elevated. The more elevated it is, the worse our patient's muscle damage is, the higher risk they are for that acute kidney injury. We will see electrolyte changes, especially like hyperkalemia and hyperphosphatemia, as well as an elevated AST. So AST is related to liver damage as well as muscle damage, an enzyme that we can see when we have muscle breakdown. So complications, again, that acute kidney injury, because we have myoglobin as well as hypovolemics. We're going to have a big fluid shift into the inflammation of the muscle tissue. And then having to break down all that protein is really, really hard on our kidneys. They can develop compartment syndrome, which can lead to muscle ischemia, which is going to worsen our rhabdo, as well as fluid sequestration. So we're going to have fluid leaving the muscle cells and causing inflammation around them, which is going to compress our veins and arteries, which is going to worsen our ischemia. Again, hypovolemia, because we have that massive fluid shift, or we're going to be third spacing. Hypercalcemia is a late sign. Hyperphosphatemia, as well as hyperkalemia, and then DIC, right? We're going to have hemolysis, from our acute kidney injury, low platelets and end organ damage, as well as those microscopic blood clots in the capillaries and arterioles of our muscle tissue, which is going to cause the thromboplastin release, right? We're going to run out of all of our clotting factors, then we're not going to have enough and kind of have this intense internal hemorrhaging. So management. So our number one management is we want to prevent that acute kidney injury or try to treat it. So we're going to have aggressive rehydration, right? Our goal is a urine output of 200 mils an hour with these patients. So we're going to rehydrate with 30 mils per kg, and then do high fluid resuscitation after that. So running like 120, 150 mils an hour. Protection of the muscle integrity. So if we have developed compartment syndrome, then we might have to do like a fasciotomy, where we actually cut the skin open so like that excess fluid can ooze out of that and not further compress the veins and arteries. And then mobilizing intramuscular edema. So with passive range of motion, and again, fasciotomy, sometimes diuretics if our kidneys can handle it. And then again, correcting our electrolyte imbalances. Sometimes these patients do just need to have hemodialysis or continuous renal replacement therapies because their kidneys cannot take the diuretics, and we need to get that fluid off of them, as well as getting rid of all of that waste products and correcting our electrolytes, which we can do with hemodialysis. And we do not want to replace calcium. So again, they might be hypocalcemic at first, but later on they're going to be hypercalcemic. So again, our job is urine output, right? We want to make sure that they're having that 200 mils an hour, assessing for T-colored urine, assessing for muscle pain, muscle inflammation, right? And then checking the CMS of all of our extremities very often. Okay, we're going to be checking each limb at least every 4 hours for range of motion sensation as well as circulation, right? We want to know the circulation of these patients. And that is rhabdomyolysis.